Hello everyone. I'm Dr. Ram Kiran KS, working as Assistant Professor in Department of Cardiac Anesthesia in UN Mehta. Today I would like to give details about the renal replacement therapies in ICU. Working as an intensivist or in any other ICU, the renal replacement therapies has become a part and parcel. So basic knowledge of this should be required for all people working in ICU. So let's move on. So basically the causes of acute renal failure in ICU are categorized as pre-renal, intrinsic and post-renal. Pre-renal could be true hypovolemia, that is because of dehydration or bleeding or gastrointestinal losses, renal losses, or it could be a functional hypovolemia in patients such as cardiac failure and sepsis. Intrinsic renal failure, acute tubular necrosis can be because of ischemic, or it can be because of exogenous or endogenous toxins. Hepatorenal syndrome, acute glomerulonephritis, interstitial nephritis, increased in intra-abdominal pressure, and vascular causes like malignant hypertension and atheroembolic conditions. And the post-renal causes are obstructive, usually obstructive causes. So what are the usual indications? So within ICU, the indications could be categorized as renal RRT for renal replacement and for renal support. So renal replacement, all the life-threatening indications like oliguria of less than 200 ml for 12 hours, anuria less than 50 ml for over 12 hours, hyperkalemia, severe acidemia with pH of 7.0, uremia and uremic related complications, dysnatremia, hyperthermia, and all this come under the life-threatening indications. Apart from that, the renal support, usually RRT is used as a renal support in ICU for the following indications, that is for nutrition, fluid removal in congestive heart failure, cytokine manipulation in sepsis, as a cancer in cancer chemotherapy, treatment of respiratory acidosis in ARDS, and fluid management in multi-organ failure. So what should the ideal RRT do? It should allow to control the intra and extravascular volume, correct acid-base disturbances, correct uremia, effectively clears the toxins, promotes renal recovery, improves survival, it should be free of complications, and clears the drugs effectively. So coming to the components, first we have to have an idea about the filters. Filters, as you can see, it is the blood flowing through the hollow fibers and the surrounding by the dialysate, which is in the counter current fashion. So there are two types of basic filters. One is cellulose based, which are not considered biocompatible, and they are usually thin and they are hydrophilic. We are using synthetic filters more often. So these are made up of polyacrylonitrile, polyamide and polysulfone. Usually these are high flux membranes and are generally more biocompatible. The flux of the membrane refers to its hydraulic permeability and how much convective transport can take place across it. So the most filters which we are using are made of synthetic and usually high flux membranes with a surface area of 0.6 to 1.2 meter square. So coming to the dialysate, there are basically three forms of dialysate which are used: bicarbonate based, acetate based and lactate based. Bicarbonate based, it is more physiological anion, but it is unstable and it has an apparent predilection to a bacterial growth, and it forms calcium and magnesium gets precipitated as carbonate when sterilized with that. So acetate, it is also physiologically compatible with blood, and it is metabolized to bicarbonate in the liver. It is more stable compared to the bicarbonate based solutions and not prone to bacterial contamination. But acetate, if it is not metabolized, it can accumulate, contributing to the cardiovascular instability with vasodilatation, hypotension, nausea, vomiting and post dialysis fatigue. So coming to the lactate, it undergoes hepatic conversion to bicarbonate on an equimolar basis, but it should be avoided in patients with lactic acidosis, hyperlactatemia and hepatic failure. So basically we need to know about the two clearance. We should have a clear knowledge about the two clearance which are happening through this filters. One is a solvent clearance, the other is a solute clearance. Solvent clearance, by default it is because of ultrafiltration, that is filtration of water from the blood driven by a transmembrane pressure gradient. The pressure gradient is causing this, so between the blood and the effluent. So this is how it is done. It is done by adjusting the effluent pump pressures as well as the pressure onto the blood side. So this ultrafiltration, this filtration of water from the blood driven by this transmembrane pressure also clears some solute along with it. That is called solute rock, and that type of clearance is known as convection, which will be going into detail. So it helps in removing the small and the medium sized molecules. And then coming to the solute clearance. Solute clearance is either convective clearance or diffusive clearance. If it is diffusive clearance, we can use the word hemodialysis. If it is convective clearance, we use the word hemofiltration. So diffusive clearance, it is analogous. If you imagine just putting a tea bag into a cup of water, because of its high concentration, it slowly diffuses out. So similar mechanism is undergone here. So if you see the blood, which is blood of the patient flowing through the filter, and the dialysate flowing in the opposite direction with a lower concentrate. Here the concentration gradient causes the solute transfer. But whereas in hemofiltration, as we discussed before, the pressure gradient, that is high pressure and low pressure created on the either side, causes the transfer of solute, and this is known as hemofiltration. And it can be imagined like an espresso, where you give some steam which causes pressure, which causes some pressure, and it spills out the beans. So this is the solute clearance. So the concept should be clear. So convective clearance is because of pressure gradient, and it is known as hemofiltration. In diffusive clearance, it is because of the concentration gradient, and it is known as hemodialysis. So as during convective clearance, since there is and during the ultrafiltration there is a loss of volume, so we usually replace that volume. That volume is replaced either as a pre-dilution or a post-dilution, that is before the filter or after the filter. So each of it has its own advantages and disadvantages. If you consider the pre-dilution replacement fluid, it dilutes the blood before the filter. So the main thing is it reduces the filter clotting, so it prolongs the filter life, but it has its downsides, that it reduces the effective clearance by approx 15%. So for this you need more replacement solution is required. So ultimately you have to increase the blood flow to overcome this reduction in the clearance. When you consider the post dilution, there is no, since they are not adding any volume before the filter, there is no reduction of clearance due to the dilution of the blood. So less replacement solution is required, but the drawback of it is it allows a filter clot. So you need a lot of anticoagulation measures to be taken. It also limits on the ultrafilter rate because of the hemo concentration of the blood. So these are the drawbacks of post dilution replacement fluid. So bringing this concept into the different modes of replacement therapies. So if you, as we discussed, ultrafiltration is just pushing removing the fluid out. So if you see the scuff, that is slow continuous ultrafiltration, here the ultrafiltrate removes the fluid, but does not provide any solute clearance here, and so it does not correct any pH, so it does not require any replacement fluid also. It just corrects the volume overload only. And now if you add on the replacement fluid, it becomes hemofiltration. So hemofiltration, here as you can see, the effluent is equal to the ultrafiltrate plus the replacement fluid. The replacement fluid, as we discussed, can be pre-dilution or post-dilution. So in the mode of CVVH, that is continuous veno-venous hemofiltration, it provides convective clearance by filtering a large volume of blood. So replacement fluid restores the volume loss. So along with it, it causes the solute drag, that is hemofiltration, which helps in correcting uremia, pH, and it can remove the volume as well. Now Coming to the dialysis, so hemodialysis is whenever you put the dialysate into the filter. So if you see here, that is continuous venous hemodialysis. The continuous the provides the diffusive clearance by running the dialysate in the opposite direction of the blood. So now you can combine all the two mechanisms of solute clearance, that is hemodialysis as well as hemofiltration, which is known as hemodiafiltration. So CVV HDF. So here you are putting you are giving the dialysate flow as well as the replacement fluid. So the effluent here would be ultrafiltrate plus dialysate fluid plus replacement fluid. So it allows fluid removal as well as correct the electrolytes and as well as even the toxin removal. So this CVV HDF is most commonly used in ICUs in patients with sepsis and all. So as we discussed, we are just classifying them as intermittent therapies and continuous therapies. Intermittent therapies, intermittent hemodialysis and intermittent isolated ultrafiltration. Continuous therapies, CVVH, that is hemofiltration, CVVHD, that is hemodialysis, CVVHDF, that is hemodiafiltration, and SCUF, which is only filtration. And in between comes the hybrid procedures, that is SLED and SLEDF. So SLED is sustained or slow low efficiency daily dialysis, or SLEDF is dialysis with filtration. So now if you see, this is the overall modes of the dialysis which we commonly use. So here we compare the three main, that is intermittent hemodialysis, CVV, HDF and SLED. So if you see, the blood flows are very high in intermittent hemodialysis because it is done very quickly. So it need very high flow rate, high flow of blood as well as high flow of dialysate. And you can do some filtration which can filter up to almost 300 to 2000 ml per hour. So basically it is done in approximately around 3 to 4 hours. So if you take up CVV HDF, here the blood flows, definitely it is done over long time. So the blood flows are at around 150 ml per minute. The dialysate flow is around 16 ml per minute, and the ultrafiltration depends on how you manipulate it. And basically, since it is continuous and it is done over a long time, it needs good amount of anticoagulations and all. So SLED, yes, it is in between these two both, in between IHD and CVV HD. So it is done over a period of 8 to 12 hours with a blood flow rate of approximately 100 to 200 ml per minute. The dialysate flow at around 100 to 300 ml per minute, and with an ultrafiltration rate of around 250 ml per hour. So this is the basic modes which we use. So now coming to the molecular weights of the various substances which has to be cleared through the dialysis. There is something large molecules which is above 5000 daltons, the middle molecules which are usually about 200 or 250 daltons to 5000 daltons, and the small molecules which are less than that. So all our electrolytes such as potassium, sodium, phosphorus are comes under small molecules. So these are diffusion here, these are cleared by diffusion better than the convention, whereas the middle molecules like B12, glucose, uric acid, creatine are better cleared by convention than the diffusion. And now coming to large molecules like beta 2, microglobulin, inulin, they are also better cleared by convention or adsorption. So nothing about 50,000 daltons usually cleared. So more than 50,000 it is albumin, so it never gets cleared. So now coming to the pros and cons of the various modes, that is intermittent hemodialysis, we usually, because the ICU is, the patients are very unstable, or usually they are dynamic patients, so we usually tend to use intermittent hemodialysis less on them. But still the pros are, it is inexpensive, it is flexible timings, allows mobility and transport of the patient, rapid correction of the fluid overloads can be done, rapid removal of dialysable drugs can be done, but rapid correction of acidosis and electrolyte abnormalities can be done. So since it is done rapidly, it requires minimum anticoagulant exposure. But what are the cons? Yes, it causes hypotension, a limited therapy duration, renal injury because of the hypotension, gut ischemia, coronary ischemia, all this can be the problems with it. And it can cause cerebral edema because the rapid changes of the electrolytes, rapid shift in the electrolytes. Now coming to CRRT, which has become popular in ICU. So the pros are, it provides a better hemodynamic stability, stable and predictable volume control, stable and predictable control of chemistry, and it has a stable effect on the intracranial pressure. That is why neuro patients with a high raised ACP, CRRT is always preferred in them. And disease modification by cytokine removal. So what are the cons? Anticoagulation requirement, and it adds on to the bleeding risk, and it is higher, there is a higher potential for the filter clotting because the flows are very low, very less in this patient and in this mode. And next is, it is expensive. Immobility or transport issues. What are there are a lot of things which are lost during CRRT, like electrolytes, especially the phosphate, which is lost. And apart from that, various nutrients are lost, and even the antibiotics are lost. So all this has to be taken care. Now coming to the SLED, which it is a hybrid, it combines the pros of both. So there is a balance here. So it allows fluid removal with better hemodynamic stability. It is independent of the available, it is inexpensive compared to CRRT, and it intermittent and downtime, allowing for out of unit procedures also. It can take, you can treat more than one patient with one machine. So it is also possible in ICU. So how do you usually dose them? So for example, if you are how to usually dose, if you are giving a dose for intermittent hemodialysis, there is something called urea reduction ratio, which is preoperative urea by postoperative urea by preoperative BUN into 100. So ideally, if it is more than 65%, then it correlates to KT by V of greater than 1.2. So that is the dose you have to, that dose is considered adequate. So what is KT by V? K is the dialyzer clearance of urea, T is the dialysis time, and V is the volume distribution of urea. But in ICU, usually the volume distribution of urea varies drastically. So we usually tend to keep the value, like we target the value of urea of around 50 to 100. So whenever you are giving for an orders for a intermittent hemodialysis or SLED with a SLED or SLED-F, you can do it like this. Mention the duration. So if it is around 8 hours, give the blood flow, which is around 200, ideally it's around 200 ml per minute, and the dialysate flow, which is you can write it as around 500 ml per minute, and then replacement fluid has to be ordered accordingly, and the heparin requirement or no heparin requirement, and what should be the ultrafiltration. So all this aspects has to be mentioned in the prescription. Now how do you prescribe CRRT? So CRRT, there are various large studies which have taken over. So ideally, the CRRT is nothing but the effluent dose, the effluent which is coming out by the patient's weight. So what is effluent in, if you take up CBV hemodiafiltration, DHF, then it is nothing but dialysate plus replacement fluid plus net balance filtrate. So if you, for example, you are giving a dialysate flow of 100 ml per hour, replacement fluid of, dialysate flow of around 1000 ml per hour, replacement fluid of around 1000 ml per hour with an ultrafiltrate of around 200 ml per hour, the total comes to around 2200 divided by weight. So the dose of CRRT would be 31.4 ml per kg per hour. So there are various studies which carried out based like dose right from 20 mils to 35 to 45 mils. Basically, the study done by Ronco et al. Showed that 20 mils had lower group showed a lower survival rate than around group with 35 mils or 45 mils. But recent studies which have been done, that is ATN trial or renal trial, showed that there is not much difference between a very large difference between the dose. So ideal dosing should be around more than 25 ml per kg per hour. So that should be the ideal dose, to around 30 to 35, not 45 or not 20. Okay. So as we know, CRRT, it requires some sort of anticoagulation. So it can be regional citrate anticoagulation, which is most commonly used, and otherwise there is any contraindication to that, then you use some unfractionated heparin. So what are the advantages of regional citrate anticoagulation? It has highest filter patency rate, no systemic anticoagulation required, so there is no bleeding risk, but there is a complexity of protocols and there is continuous monitoring which is required, and there are risks of citrate toxicity on metabolic alkalosis as well. So unfractionated heparin, it is easy to use, easy to monitor, and easy to reverse with protamine, but it is associated with systemic anticoagulation and bleeding risk. Apart from that, other agents have been used, like low molecular weight heparin, thrombin antagonists have been used, but less commonly used. So coming to a general protocol of regional citrate, for example, you start with a pre-dilution fluid containing citrate of around 18 millimoles. So that is passed, and then when it passes enters gets mixed with the patient outflow, it chelates the calcium. So the calcium, once it goes into the filter, so and comes out of the filter. So post filter, normal calcium in our plasma is around 1.01 to 1.2, but because of this citrate, we are reducing, target calcium should be reduced to less than 0.5. So that should be our target. And what should be the target citrate levels at the filter? Should be around 18 millimoles, which we are giving. Should be the target of citremia should be around 2 to 3 millimoles per liter. So once it passes out, then you have to since it is now the blood is going into the patient, now you have to supplement some amount of calcium. So that calcium is supplemented either in the post dilution fluid, or some amount it is transferred to the dialysate also. So basically you have various protocols to maintain the adequate calcium levels post filter and the adequate citratemia in the filter. So these are the various protocols which are described below in the figure. So now coming to the drug dosing. So the various drugs which we used has to be dosed, because some drugs are filtered, cleared very well, and some are not cleared. So basically we have to know what are the factors affecting it. One is the volume distribution. For example, if there is a higher volume distribution, it is lipophilic, so RRT clearance is unlikely. Lower volume distribution, then it is hydrophilic, so RRT clearance would be likely. Coming to the molecular size, bigger molecules are always better cleared by hemofiltration, whereas smaller molecules are better cleared by hemodialysis. So for example, bigger molecules like antibiotics, if you take vancomycin, teicoplanin, are cleared by hemofiltration than by hemodialysis. And then is plasma protein binding, higher binding, less is the clearance. So this basic knowledge we have to have. And now this is a chart describing the various antibiotics used and their dose, which has to be changed in intermittent hemodialysis, SLED and CRRT. I'm not going into detail of each and everything, but broadly if you talk the drugs which does not need any kind of dose adjustments are ceftriaxone, tigecycline, clindamycin, azithromycin, doxycycline, minocycline, amphotericin B and caspofungin. The drugs which are highly cleared include amikacin, gentamicin, fluconazole, ceftriaxone, and vancomycin and tazobactam. So these antibiotics has to be dosed properly. So the dosages are given of the common antibiotics which we use. You can just go through the slide. And what is dialysis catheter dysfunction? So some extra aspects regarding the renal replacement therapy. What is dialysis catheter dysfunction? So ideally, ideal length is very important. The site of catheter is also very important. Preferred catheters would be right internal jugular vein, followed by the right subclavian vein, and then left interjugular vein. The least is preferred is, and left subclavian is the least preferred. So the ideal position, if you put a right IJV, it should be at the SVC-RA junction, minimum of around 20 centimeters. If you are putting a femoral catheter, the ideal length should be more than 24 centimeters. Left subclavian least preferred. So dialysis catheter dysfunction, there can be, it can occur, and how it is detected. Usually the arterial and venous pressure alarms are buzzing out, and then they decrease the pump flows and they lower the value of urea reduction. So how to react? So minimize internal and external thrombosis. You can use Heplock and all. You can give heparin flushes, intermittent heparin flushes and all. So avoid procedural complications, and you can always switch the inflow and outflow cannula, but this can cause some amount of recirculation, so it cannot be done for a long time. So when to start renal replacement therapy in an ICU is a question. So basically there are many trials which have been carried out from large trials which have carried from 2002 to right to latest 2020. They all say, like, they all have different timings for their early and late dialysis, but none of the studies showed some basic difference in the morbidity or mortality of the patients, except in fact the Elian trial, which showed that early RRT was in fact decreased the mortality. That is the only study which showed some benefit. Rest all didn't show any significant benefit, because early dialysis has its own pros and cons. For example, if you take the pros, there is an avoidance of emergent electrolyte abnormalities, avoidance of marked hypovolemia, simplified management of non-renal disturbances. It allows initiation in a controlled setting. It has its own cons, that is increase in number of dialysis catheter days, associated complications, and dialysis of some that will recover prior to absolute indication of renal therapy. So there are some patients in these trials which have recovered without dialysis also. So that is why when to start, it is subjected to the institution protocol. So the common protocol, which is a furosemide stress test, can be used as a guide to resuscitation. So how do you do that? For example, if the patient, how do you know that the patient is a candidate? Patient has to be adequately resuscitated. There should be a persistent oliguria, and doubtful that a fluid, vasopressor or inotropic channels would help. So in them, for example, the patients who are not on prior furosemide, you can give 1 mg per kg IV bolus. If the patient who are already on IV furosemide, you can give up to 1.5 mg per kg IV bolus. Then watch for a urine output for about 2 hours. If urine output is more than 200 ml, the patients are categorized as pre-renal oliguria. If the urine output is less than 200 ml, it is an intrinsic renal failure, which points towards early renal replacement therapy. So this can be used. So what are the other things which will help you for better carrying out the better renal replacement therapy in ICU? First is choose RRT based on the hemodynamics, a primary reason for RRT based on cost implications and other logistics. So follow the rule. For example, blood flow should be greater than 2.5 times the dialysate flow, and it should be ideally around 4 to 5 times the replacement fluid flow. So this should be the target to maintain the filter properly, for effective function of the filter. So in pediatric dose, if you considered the weight based doses, ideally in pediatric the blood flow can range from around 3 to 10 ml per kg per minute. If you take up the dialysate or the renal replacement fluid dose, can range from 20 to 40 ml per kg per hour, and if you ultrafiltrate, should be around 1 to 2 ml per kg per hour. So CRRT, whenever you are starting in ICU, go with high filter which can do all the things. Like for example, you take up a CVV HDF, so they first carry out that, then you can change according to the patient dynamics. Say for example, if patient is having severe electrolytic derangement, so in them electrolyte degeneration, as you know, these are smaller molecules, in them are better cleared by hemodialysis, so CVV HD is better. So you use higher diffusive clearance, so higher QD. For example, if patient is in sepsis or some sort of myoglobin and all, so like increased large molecules, so CVV HDF, because use higher convective clearance, so use higher replacement fluid flow. So accordingly you can change the diffusive clearance flow, or that is dialysate flow, or the convective clearance flow, that is replacement fluid flow, and always keep the filtration fraction less than 30%. What is filtration fraction? That is total output, that is total effluent to total input before the filter. So in broad terms it is like this. So for example, if you are taking CVV hemofiltration, total output would be, the effluent would be the replacement fluid plus ultrafiltrate, okay, and the denominator, that is the input, would be the replacement fluid, and you should take the plasma, that is blood flow into 1 minus hematocrit. So ideally, if you're using if your filtration fraction is less than 30%, it indicates that your filter is getting clotted. So in them you increase the blood flow rates. For example, if you increase the higher blood flow rates, then the filter, since it is in the denominator, your filtration fraction is obviously lowered. And for example, if you take up the pre-dilution filter, so if your replacement fluid is in the pre-dilution, then also it is added up to the denominator, so then also that also decreases the filtration fraction. But if you are taking, for example, if you are taking the post dilution replacement fluid, so that is not getting added to your denominator here, so your filtration fraction is increased, and which can clot the filter. So these are the things you can play with the flows of the various modes, and then change, it can be changed according to the patient's dynamics. And then what are the common filters which we use? So in our setup, we usually use the M100 filter, which is an acrylonitrile 69 filter in an adult patient. The blood limit of it is around 75 to 400, so it is basically used for CRN. And there is something called Oxyris filter. So Oxyris filter, it is used for the endotoxin and cytokine removal. It can be useful patients who are suspecting sepsis. It basically has 3 layers. The one is the third layer, which is in contact with the blood, is the heparin graft. The second layer is an endotoxin used for endotoxin removal, and the third layer is used for cytotoxin removal. So this can be also considered in patients with sepsis. And apart from that, now we have filters which can perform the role of plasma exchange, that is a polypropylene filter, that is TP 2000, which is available. It exchanges plasma in 1:1 ratio under proper monitoring, so that can also be considered. So now if you just take the basic fluids, the basic fluids which we used in our CRRT machine, I have just tried to color code the fluids which we commonly use here. The yellow one which is there, it is usually the effluent. The one which is used, it is usually the citrate containing fluid, which is given as a pre-dilution fluid. So it contains 18 millimoles of citrate, apart from that sodium and chloride, which is used. And the second one is the dialysate. It is bifossil. So here it contains the various electrolytes as described. And the third fluid, the coded in blue, is usually the post filter replacement fluid. So it also contains sodium, chloride, dextrose, and it basically contains higher concentration of calcium, because of the citrate which we use, the calcium levels which we target just immediately the post filter. Based on this replacement fluid, we can bring it back to normal levels. So other contents such as magnesium and all are also used. So these are the basic stuff which we commonly see in our ICUs, and I just try to brush out few important aspects of this venous replacement therapies. Thank you.